This section is about the growth of the face. The face grows and it changes. In medicine, this basic knowledge has an influence on orthodontics and the possibilities of treatment. The name orthodontics already says what it is. It is a matter of intervening orthopedically in this growth of the face, which after all consists to a large extent of the jaws. Whoever understands the biological background of the growth of the face will be able to choose the right therapeutic approach, which is individually adapted to the patient sitting in front of us. This section is about the growth of the face. The face grows and it changes. And therefore, our learning objectives for this section that we want to create an understanding of the principles of the shape development of the face, the interaction of the tissues and the importance of the teeth for growth. And this includes knowledge of bone remodeling and also knowledge of the location and the importance of the sutures. And of course, we always include clinical hints where appropriate. It's going to be a long lecture. So here is an overview of the chapters. First, we will briefly look at the condition of the skull at birth. Then we will look at the changes in the proportions of the face, and here we will go briefly back to the prenatal period also. We want to know how the face grows, so we have to look more closely at how the bone remodeling processes take place in the face. We will also address what happens in the sutures and also speak about the importance of the development of the dentition. We will only briefly address the paranasal sinuses, but then we will look at the puberal growth spurt and its usability in the context of functional orthodontics. And here, the typical architecture of facial growth types will be covered, and also the soft tissue influence plays an important role. And finally, I will explain that facial growth does never stop throughout life, and what consequences this has for dentistry, for orthodontics, and for maxillofacial surgery, not only in the case of unfavorable growth patterns. If you want to read more about how the face grows, I can recommend the Handbook of Facial Growth by Donald Enlow, or my textbook Oral Structure and Biology. That is actually the blueprint of what I explain here in this lecture, and therefore I have always included the related page numbers in the upper left corner of the pictures. The growth of the face can be shown very impressively if we arrange a series of skulls here on the table from the time shortly before birth up to the adult time. And there we can already see impressive changes in the proportions of the individual parts of the face, which we now want to cover in more detail. Let us first note how the situation is at the time of birth. The cranial sutures have approached but are not yet firmly interlocked. The fontanelles are still wide open and the base of the skull is mainly characterized by synchondroses. Remnants of Meckel's cartilage are still present as pieces of cartilage in the region of the symphysis menti. The mandible is not yet firmly fused in front, the symphysis menti is therefore still somewhat open. And regarding the condition of the dentition development, all the crowns of the deciduous teeth are completely mineralized, and in the permanent teeth, mineralizations of the hard tissue are already detectable at the incisal edges of the incisors and at the cusps of the first permanent molars. And overall, the oral cavity still accounts for a relatively small proportion of the face and the skull, which will of course change considerably during the course of facial growth. Have you ever looked at childhood pictures of yourself and compared them to how you look today? Some people do hardly recognize themselves. Here at one of the master classes at the pediatric dentistry at Marburg University, some of the participants had such pictures with them, and it was not so easy to assign who was who on the childhood pictures. I do not know how the passport authorities at the borders manage to identify children on the passport pictures where the children's pictures are valid for several years and when they already have reached their puberty. I don't know how to do it. The entire body undergoes impressive changes in the proportions of its individual parts. In the babies, the head is quite large and the legs are still quite short. This changes in such a way that the subcranial part becomes larger and larger. The arms and the legs become relatively longer and longer, and what all the babies can easily do, namely put their feet in their mouths, is something that we as adults would hardly want to try. But not only the whole body changes in proportion, it also affects the face itself. Here also impressive changes of proportions can be seen. If we look at the faces of my two granddaughters in comparison, you can see the older one on the right, she's 4 years old, and the smaller one on the left, who is 7 months old. And immediately you will notice clear differences in the vertical structure of the face, which I can still clarify for you by these lines. If we take the eyebrows as a reference, the second line of the older one on the right intersects the tip of the nose, while the tip of the nose of the smaller one on the left is clearly above it. And where the lowest line just touches the chin of the younger one on the left, it is at level with the lower lip of the 4-year-old. The vertical changes are also quite clear here. You have probably noticed the same changes with the Harry Potter actors, especially with Daniel Radcliffe on the right. The round childlike face has changed over time to the clearly more vertical face of the adult theater actor. And exactly these changes is that we also want to follow in our patients, which is why we always take these photostat images and we evaluate them during our orthodontic treatment. And here too, it is clear how the round face of the child at the age of 11 has gradually gained more and more vertical length until it has changed and become the angular face of the young adult. Now we want to elucidate these changes of the proportions of the face more in detail. As so often, we find clues to fundamental processes if we go far back into time of the development of the individual. So we now go to the prenatal developmental time. Here we have a specimen of a head from the 5th prenatal week. We can see that the sutures are still far apart and the visceral cranium is much flatter than the neurocranium. As a measure for the vertical development, which we now want to follow over time, the orbit is a suitable marker. The orbit remains quite constant in size over time because the eye does not grow that much anymore. At that time, it has almost reached its actual size, while everything else is still growing. So, under the orbit, in this fetus of 5 months, there is only room for one more orbit underneath, and then the edge of the lower jaw is already reached. If you look at yourself now in a mirror or take a quick selfie, you will see that in the adult face, there is space for at least 3, 4, or even 5 orbits underneath until the edge of the lower jaw is reached. If we go a little further into the 8th prenatal month, then not so much has changed. The sutures came a little closer together. They have not yet fused though. Almost all the sutures remain open for life. Only the symphysis menti, that's closed in school child, and the frontal suture closes when we approach 80 years of age. All the other sutures remain open for life, with a certain inherent mobility as the osteopaths have shown us. But let us go back to the orbit as a measure for the vertical development. There still is only space for one more orbit under the real orbit. Here we also take a look at the maxilla and the mandible in the horizontal plane. For now, only a little thicker are the ridges in which the teeth have developed and became larger. It will be more interesting in later stages then. Let us go on. Birth has now taken place, or the child would be 6 months old. You cannot really tell exactly from these macerated skulls. In any case, you can see the fontanelle is still open and the sutures have moved closer together. And if we now take the orbit again as a measure, then you can see it still fits only one orbit underneath. With the baby you can see this clearly. The cheek fat has to go somewhere, so vertically there is not much room for the chubby cheeks of the babies. In the frontal view we also see how small the maxilla is. The infraorbital foramen also provides a nice scale. Also the diameter of the nerves does not change that much from this time on. They almost have reached a definite diameter now. And you see the teeth have erupted through the bone, but they still have to emerge through the gingiva. Now we are making a big leap. Our skull model has reached the age of 6 years now, and the primary dentition has been completed at this, and it is already starting to be replaced by the permanent teeth. The lower anterior incisors are erupting, and the first permanent molars have also erupted. This is associated with a raising of the bite, and you can see from the orbit there is only barely visible the lower margin just at the top of the image. And now it is interesting to take a look from the occlusal aspect as well. Let us focus on the upper jaw. We see an early mixed dentition. The 2 first molars are there, tooth changes beginning in the incisor group also, and otherwise the primary dentition itself is still complete. And we see that the second molars are already erupting, at least within bone. It is interesting to see that they themselves trigger the formation of their own periodontal bone. So teeth create their own bone. The other interesting point in this picture is the position of the suture between the palatine bone and the maxillary bone. The suture is at about level of the 2 first molars at this time. Let us keep this in mind for a minute and let us compare this with the further development some slides later. And if we now look at the adult, the orbit at the top of the picture is no longer visible. There has been a much greater vertical development now. The adult dentition with its long roots is now complete, except for the wisdom teeth. Here is another hint which also has great clinical relevance. On the first bicuspid we see here a fenestration, which means there is no more bone above the root. And this is in this young adult. And by the way, this is a finding that we know better now than it was a few years ago. Today we use more and more 3D cone beam CT technology for diagnostics in justified cases, but there are many more than in the past, and we did not have this technology then. And so we now see a prevalence of such fenestrations in young adults of about 36%. A graduate student of Axel Buhmann did this investigation, and we have to take this into consideration when we aim at a transversal expansion of the dental arches. We must not risk that more teeth with even more areas of their roots are left without any bone. Now we come back to the occlusal view, and we can compare it to the earlier situation when we discussed the situation in the 6-year-old skull in the same view. The second molars are of course now already properly in occlusion, and now the third molars are doing exactly the same what the second molars did some time ago. They are forcing themselves into the back of the dental arch, there at the posterior margin of the maxilla, and along the way they are creating their own bone. So we see that teeth themselves trigger the formation of bone when they emerge. How this is biochemically regulated, what exactly happens in this tooth-bone interface, is now quite well known, but we do not need to go into all the details here now. And if we recall again the suture that runs between the maxillary and the palatine bones, it was previously between the 2 first molars, and here it now runs between the 2 second molars. From this observation, we may conclude now that everything is in motion, that teeth can change their places also in their relation to the bones on which they are standing. That's an impressive observation, which has didactically its sense, but purely scientifically, we must restrict ourselves cautiously. We have here only a small selection of skulls. N is not only 2. So we would have to examine that actually again with a higher number of specimens. It may also be only an individual variation. Well, let us leave it like this. In this arrangement of skulls, we can see that the orbit is a very nice reference to describe the changes of proportion in the skull during its vertical growth. And starting from the newborn, then in the child, and in the school child, and in the adult, we then have an enormous increase in vertical development. It is in this region where most of facial growth takes place. If the skull is marked in color, which means the neurocranium is stained orange here, then it becomes clear what impressive growth takes place in the viscerocranium in vertical, transverse, and in sagittal directions. The question is, how does it grow exactly? We know that trees show such typical annual rings, but the question is, how do the bones of the face do that? There, the forms and the proportions are still somewhat more complicated, aren't they? So let's try out a little sketch on the blackboard. You can also do it yourself on a piece of paper. We will draw a little mandible, and we want to see how it grows. This mandible that I grow here is just the body of the mandible without any teeth. So we go layer by layer, and we try to see how the form is changing so much that we can no longer realize this is a mandible. So this must be wrong. This cannot be the case. We can check also with some bone from the extremities, like take the little humerus here, like that little dog bone, when that grows. We can do it like we do with this incremental lines. Let's see how it works. If we just go layer by layer, as you can see, if I go on with this, it quickly loses its form. So that's not the way how it is. We know how it is. It is, I try to sketch that also, it is so that we have these this little bone here, and then we have these epiphyseal cartilaginous discs here, and these discs out of cartilage are expanding and pushing up and down here the long bones and make them longer, and the shaft of the bone is not getting that thick, so we can have it like this. And of course we have the displacement of the epiphyseal cartilaginous discs. So now this is how it works with the long bones, but the question is, how does it work with the face? What we have just seen on the blackboard, how the humerus grows and how the epiphyseal cartilaginous discs in particular are responsible for its growth in length. This is true for all limb bones, but what about the face? There, the conditions are somewhat more complicated. But there are other principles of growth, and Donald Enlow was able to explain to us how the face grows. He was also an anatomist and an orthodontist, and he visited me on my birthday more than 20 years ago. And these impressive drawings with the arrows, which everyone probably already knows from the textbooks, go back to his work. How did he come up with it? In the 60s of the last century, he was working on this question, and he saw that the child's mandible, which is naturally smaller than that of the adult, it did not fit into the larger mandible of the adult. And in the view from the side, it becomes even clearer. If the ramus of the mandible grows in the direction of the temporomandibular joint, it becomes larger dorsally, and then it must also be reduced at a corresponding degree at its front. If not, then it would become more and more bulky. And that is obviously not the case. So if we talk about growth, it is not always just increase, but there also must be an appropriate amount of reduction at the same time. And this principle serves to preserve the basic form, whereby the entire bone nevertheless becomes larger and also changes a bit of its proportions. But its basic shape remains, well, much different than from what I have drawn on the blackboard. And this interplay between growth and resorption, that is called remodeling. And this is one of the basic principles of the growth of the face. These complicated looking images now show this in a spatial context. Let us take the mandible as an example here. The gray arrows show regions of bone production, and the red arrows show regions of resorption of bone. And in the condylar area, there is an enormous growth of bone, which reaches out backwards and upwards, but also out to the sides. And at the same time, however, we also see red arrows at the inner sides of the ramus, which indicate bone resorption there. And this makes the mandible wider in its posterior part, but without making the ramus too thick. And thus, the V shape of the mandible is maintained during growth. And so the ramus of the mandible does not only move backwards, but also outwards to the sides. And also at the anterior margin of the mandibular ramus, we see a big red arrow. And this bone removal creates space for the eruption of the posterior molars and compensates for the growth at the very back of the margin of the ramus. You can also apply this principle to the maxilla and to most other bones of the face. This is the basis of the reshaping of bones during growth. Bone responds to forces that are converted into cellular reactions, and we can use this knowledge for orthodontics and for craniofacial orthopedics. Well, it is a bit more complicated. Frans van der Linden has illustrated the effect of sutural growth on the face in this diagram. The scheme reduces the situation to the two-dimensional plane. This is already complex enough compared to reality in 3 dimensions. Each of the sutures here in the picture has an effect in vertical and in sagittal direction. And depending on the position, depending on the inclination in the skull, their shares in vertical and in sagittal directions are slightly different. Let us take, as an example, the spheno-occipital suture, which is shown here in green. It is located at the base of the skull, and because it lies so obliquely in there, it also has shares in vertical and in sagittal directions. And depending on how differently it is inclined, and this can only be small amounts, its effects are nevertheless different. You can now imagine, as there are certain variations within every human being, then the faces also look slightly different, and that way we can recognize each other. And the same applies then also to the other sutures, which are shown here in red. We do not need to discuss them all in detail now. You can imagine that they change the shape of the face with further different growth. And if we now also imagine that not every suture grows at the same time in the same rhythm with the others, then you can also understand why the faces change so much over time of growth. And this is especially impressive during puberty. Then we observe almost an explosive growth of the cartilage. The articular cartilage is shown here in blue, and the cartilage of the nose, the inner nose with its septum, and also the outer nose, which is also cartilaginous, is not included in this diagram. But this cartilage also grows particularly strong during puberty, and that is why the faces of these growing children also look somewhat disproportional at certain times. This is not easy for everyone to cope with. We know this from our own puberty time. But in the course of further facial growth, it usually comes back to more harmonious proportions. At least that's how we realize it. And another aspect is interesting. Have you ever seen, maybe on Discovery Channel or on YouTube, how a flower grows? I recall a movie that once showed, it was in time-lapse photography. You can see how much it jerks back and forth. It is not at all a harmonious flowing change. When I was a student in embryology in Göttingen, we also saw this when we made time-lapse movies of growing embryos. It is impressive how they jerk and bow to either side there while growing. And for the jaws, it is also like that, and it becomes clear why also at times when unequally growing jaws, the teeth sometimes also do not fit together exactly. In the deciduous dentition, then, extensive abrasions show up. And this is then very practical because that way the teeth do not disturb the growth of the jaws. This may also explain why some adolescents have temporary discomfort in their temporomandibular joints. This can also be due to a temporary discongruence of all components, bones, teeth, joint, and also soft tissue. Jos Dibbets, the former orthodontist in Marburg, has shown that in a prospective study that temporomandibular joint symptoms in adolescents do not always show the need for immediate intervention. He found, in many cases, it balances out itself. The cells of the sutures, in any case, they don't know anything about what they do with the face. They behave only in accordance with their genetic code. They tells them to grow, to multiply, to produce the sutural connective tissue, to initiate ossification at the edges of the sutures, and on and on and on. What effects this has on the shape and on the development of the face is a remote effect of the sutural cellular activity the cells in the sutures are not at all aware of. As a result, this leads to this kind of growth of the face, diagonally forward, downward. There may be individual variations from person to person. Some are more forward, others are more vertical. This has been found out by means of series of lateral head film radiographs on the same persons, in other words, on longitudinal studies. This amount of cephalograms, which used to be made in series today, is no longer possible to the same extent, for reasons of radiation protection. So, these images, when superimposed on the base of the skull, show how the face grows in a slanting forward-downward direction. A large part of this is due to the development of the dentition, as we will see in a moment. In this series of pictures, we can see the importance of the development of the dentition for the overall development of the face. In cases of anodontia, we would then have correspondingly unfavorable effects of the vertical dimension of the face. You can even see here how much the alveolar process grows. Here an implant was placed on the upper right lateral incisor in a child or in an early adolescent. This was certainly well-intentioned, but you can see here very clearly how strongly the alveolar process develops in vertical direction and the implant remains in its original position. Neither the maxillary sinus nor the other paranasal sinuses are really present at the time of birth. They arise as further invaginations of the epithelium which is lining the nasal cavity. Under this slight but constant pressure, the underlying bone is being resorbed and cavitated. The maxillary sinus develops in the region of the later hiatus semilunaris. That's a small depression, as small as a pea in a small child. In the middle nasal meatus, under the middle turbinate, that's the place. The epithelium continues to expand, and at school start, the maxillary sinus is about the size of a cherry. And in the school child then, the maxillary sinus has already spread throughout the maxilla, and it is about the size of a chestnut. And in the adult, it has increased significantly in size, and in old age, it almost completely hollows out the maxilla. And those of you who wish to speculate on the purpose of the maxillary sinus may do so. In any case, it does not serve the purpose of saving weight. For that, its volume share is again too small. It also does not serve as a swimming aid as actually been described in the literature. No, it's just simply there, a consequence of the ever-progressive expansion of the epithelium. This process has already taken its beginning at the embryonic times. In any case, the maxilla is increasingly hollowed out by the maxillary sinus. And here on the left you can see the maxillary sinus of my daughter. At that time she was in her mid-20s as a student. Yes, the atlas, the face, was made on the basis of MRI images on the living, so my daughter was the model for it. You can see how already the molar roots are still well set in the bone. And in the picture on the right, that is my own maxillary sinus. As an exception, we also have a picture of me in the atlas to show how much the maxillary sinus expands and how the root tips of the posterior teeth protrude into it at the bottom, covered only by a thin layer of bone and the maxillary sinus mucosa of Schneider's membrane. And now it becomes clear why there are dentogenic sinusitis and why the teeth can hurt when we have a maxillary sinusitis. In this section, we will focus on the puberal growth spurt. Probably all of us can still remember that time of our own puberty. Also the fact that at that time, when we were around 10 to 12 years old, there were also clear differences between boys and girls. So we male found that the girls in the school class became funny, and the girls found us boys quite retarded. There's just this difference of the sexes. The girls have their puberal growth spurt at about 10 years and the boys 2 years later. The hormonal changes are manifold. And when the entire body shoots up in a very short time, there's also strong growth in the face. In addition to the effects of the hormonal changes in the skin, the face also becomes very disproportional at that time. But facial harmony comes back soon. If the mandible is too short, then the puberal growth spurt is the best time to treat this. Children with a deficient mandibular development should be seen by the orthodontist at the age of 10. This is true for girls who are 1.5 or 1 to 2 years ahead of boys, but there are individual differences. In any case, this is the ideal time for a sagittal development of the mandible. We can also determine very precisely the appropriate time for the growth peak. For decades, the hand-rest radiograph was used for this purpose, but since the work of Franchi and Bacchetti 20 years ago, this is no longer necessary. The growth spurt can also be recognized by the maturity of the cervical spine, which is always shown in the lateral head film anyway. The success of functional orthodontics is based on the knowledge of growth and the possibilities of influencing it. This is the basic domain of orthopedics, and nevertheless, the possibilities of functional orthodontics, the possibilities of promoting growth of the mandible, are also vehemently doubted by some people and are also cause for many discussions in the public. But no doubt about that, there is this growth spurt during puberty. Everyone has gone through it, you cannot forget that. And we must make use of this growth spurt in orthodontics and in craniofacial orthopedics if the lower jaw happens to present a lack in growth. More than 50% of our patients have a mandible that is too short due to insufficient growth. And then of course, then also the teeth will not interdigitate properly in occlusion, and in the frontal region of the dental arch, the teeth show an increased overjet. But if the whole body grows by 10, 20 centimeters in a short time, then you should get another 5 or 7 millimeters for the lower jaw to come forward, mostly with the help of an orthodontic appliance. Of course, this must be worn by the patient, despite puberty. If you do not wear the recommended appliances, then there is a high risk of great damage. If the lower jaw stays too short, the front teeth do not come together properly. It gets worse and worse, as you can see here. The daughter on the left and the mother on the right. The mother was not treated at the appropriate time, and now her lower teeth are biting into the gums behind her upper teeth. There are many methods and orthodontic appliances that can be used to specifically advance growth of the lower jaw. I do not want to commit myself here as to what might be the best appliance or something. All patients are different and they have their preferences and what they want to wear and what they want to have. And many orthodontists do it their own way. In addition, there are always new technical developments in our field. But there's one thing that can hardly be changed, and that's biology. Our body needs to be able to react to the devices, and that takes time. So I recommend wearing the appliances 24 hours a day, with some exceptions, of course. But if you only want to wear them at night, then you know that is not going to work, because it's going back and forth, and at the end it doesn't go anywhere. And there are some critics, also among orthodontists, who maintain that such functional orthopedic appliances do not work at all. Well, there are some complicated cases that may not work out well. But anyway, you have to wear the appliances the way it was negotiated with the orthodontist. But when the lower jaw is therapeutically advanced forward, it has taken with it also the teeth, and then they interdigitate in a proper way, eventually. Many people always refer to these studies by Caroline Albers and Luc Dermot, and then they conclude activators don't work. But if you actually read them, the activator effect is 60%. It works on the mandible, and yes, it also has a dentoalveolar effect as well, which is a good thing. And of course, there are different geometric configurations of people's faces, and if you evaluate the different growth types altogether, so in one group, unfavorable ones together with the favorable ones, I think 60% is really a good share. And of course, the problem is the control groups. In studies, the criterion of seriousness, also often called evidence, is always the correct selection of control groups. But if I want to test the effect of functional orthodontics, how can I exclude a control group from active treatment that is a group that does not receive treatment, even though the favorable time window is the growth spurt during puberty? So from the ethical standpoint, that is impossible. So I use functional orthodontic measures to influence facial growth. I also know that they do not work for some patients. The reasons are numerous, but not doing it would mean denying the child the chance to at least give it a try. There is a chance to success. Here you can see a patient case of mine, a patient with a unilateral dysplasia of the temporomandibular joint, in whom I was able to stimulate and to control growth of the mandible with functional orthodontic measures in such a way that she gained almost 1 centimeter increase in length of her mandible within 2 years. For me, this is a proof that we can influence the growth of the mandible therapeutically. When this patient keeps her mouth closed, it is not immediately visible in the anterior view. She suffers from a dysplasia of her left temporomandibular joint, which is associated with a significant consequence for the facial skeleton. When she smiles, it is already obvious. And when she opens her mouth, then you see there is a progressive deviation to the left. The mother told us that she suspects that the cause could be a birth trauma. That is, her daughter was born in a strong dorsally flexed head posture, nose first, with possibly particular pressure on the temporomandibular joints, particularly on the left. This could be a cause, but we have not been able to confirm this further, and we did not want to pursue it further. So the panoramic radiograph was calculated from the volume data set of a 3D cone beam CT. And here we see a certain deficit in height in the left ramus, and no regular condyle is recognizable, and no mandibular fossa. In the images focused on the joint calculated from the cone beam CT, we see a regularly formed temporomandibular joint on the right and a dysplastic condyle on the left, which is bent medially, and no mandibular fossa that have not been formed. And in the individual sections, it becomes clear once again. On the right, a regular temporomandibular joint, and on the left, a dysplastic one. The 3D volume shows a clear deficit in height on the left, but it also affects the maxilla. The occlusal plane is inclined to the left. Also, in an oblique view from the back, there is a normal joint on the right, but on the left, the condyle is dysplastic and bent medially. And in a caudal view, we see the asymmetry of the mandible. The question is, well, what can we do therapeutically? In any case, the temporomandibular joint is actually a widely pressure-free joint, which means no real hinge with force transduction like many other joints in the extremities. The mandible rather flies, so to speak, supported within all the muscle loops, and the temporomandibular joint merely serves as a guidance posteriorly. We had several consultations with the maxillofacial surgeons. We decided that we would not go for surgery with a temporomandibular joint prosthesis. Instead, we wanted to treat as much as possible orthopedically, which means through bone remodeling, in order to adjust the length and the height on the left side as much as possible. So we first treated with the functional regulator according to Frankel's. This is known for its ability to model alveolar bones even vertically. And after that, we used an activator. With that, we could further adjust, especially sagittally. It was also vertically ground free in order to achieve as much extrusion of the teeth as possible on the left, with the effect to further adjust the inclination of the occlusal plane. And 2 years later, here again a panoramic radiograph calculated from the cone beam CT. The development of the dentition is physiologically correct. The condyle on the left did not get any much better, of course. I didn't even expect that. What do we see in the 3D images then? As I said, we could not regrow the condyle. The finding remained almost the same as before. Also on the digital slices, we do not see a significant change. But the functional orthopedic correction has to a great extent resulted in a correction of the inclination of the occlusal plane. It is no longer that much inclined upwards on the left. So, if we compare the initial findings with those of 2 years later, then it becomes clear how much a vertical development we were actually able to create on the left side. The asymmetry is visible and the caudal view has not changed much. But let us have another look from the left side. Here we really see the success of this treatment. We have developed the left half of the mandible by as much as a width of a finger. We have achieved almost a bilateral congruence with regard to the mandibular body. What is left now is actually a dysplastic condyle on the left side. So, the view of some people who maintain that functional orthodontics is ineffective and that you cannot influence growth with it, well, that is probably not true after all. The individuality of the face, the different proportions of the different faces, this all goes back to the variability of the form. So let us take the mandible as an example. All these mandibles here are all correct mandibles. They only differ in terms of their jaw angle, from an almost right angle on the upper left to the wide open jaw angle on the lower right of the picture. And the growth direction of the condyle is also indicated by that red arrow. And in this way, the mandible changes its position as it grows in the different directions. And here you can see two extremely differently growing individuals from the skull collection of Arne Björk in Copenhagen. On the left, a skeletally open bite, and on the right, a deep bite. As you see, the skull configurations are clearly different. Let us first look at the right skull. That is a skeletally deep bite. It is not only about the bony shape, it's also about the question what type of person has or had the skull. On the right, the temporal fossa is clearly deeply pronounced. And if you look around in the Natural History Museum, you can see even much deeper temporal fossa. There are animals that have a huge, powerful temporalis muscle. This voluminous muscle has then deeply displaced the bone in that region. And in the skull on the right, we also see the tuberositas masseterica, that is the attachment zone of the masseter muscle, which has left these scalloping rough ridges on the sides of the ramus. From this we can conclude to a powerful activity of the masseter muscle. So a person who bites together so powerfully with such a strong musculature, this is perhaps also the cause for this form of the cranial bones. In any case, this deep bite is a skeletally deep bite. It literally squeezes its alveolar processes. The opposite is the skull on the left in the picture. You can hardly see the extension of the temporalis and the fossa. Very weak, very thin, very little impressions. Also so for the masseter muscle. And as a result, the mouth is much more frequently, probably always open. The lips cannot be closed at all and over the frontally open bite. And the tongue is possibly constantly located between the teeth in front. So this is a completely different type of person, and you surely have some of them in your surroundings as acquaintances or as patients. The left configuration is called dolichocephalic, and on the right it's the brachiocephalic. And what we see here are extremes. Our patients are somewhere individually in between, and we get the minute details when we analyze the lateral head films and when we fill in the cephalographic analysis. Our therapy must then be based on this. On the left one, if the open bite is to be closed, should be attempted much earlier than in adults. These are adult skulls. Then at first, the soft tissues must be controlled. The patient must learn to perceive and to control them. So speech therapy comes into question here as an adjuvant therapy. And in the right one, yes, he must also learn to let loose, to let go more. With orthodontic measures alone, it is difficult to fight against such strong muscles. And nowadays, Botox injections are also used to temporarily reduce the activity of the muscles by selective paralysis. But this is not very sustainable, I see. Here is another important note on the function of the soft tissues. They also have a lasting influence on the growth of the face. Bone always reacts to forces exercised by its environment. And we know that if the tongue lies against the palate and the perioral muscles help to balance the force systems from the outside, and the dentition can develop in the space which is left between the tongue, the lip and the cheek, and the palatal arch has the correct shape. However, if the patient has difficulties in breathing through the nose, that is, if he always breathes through the mouth, then inevitably the tongue must lower down. It can then no longer support the palate from the inside. Then the cheek muscles, which are also more tensed due to the open mouth, gain the upper hand, and there is a compression of the maxilla. For the nasal passage of the air, this is yet another factor to the deterioration, and it's a vicious circle almost. And the tongue, which now lies further down, presses against the posterior teeth in the lower jaw, with the result that it also contributes to the formation of a lateral group crossbite, if it had not been already appeared as such, due to the too narrow palate. For children, this means a growth inhibition of the maxilla. Now we see an impressive simulation of the growing skull. We start at 6 months of age. Look at the eye sockets as a reference. They always stay at the same size. And now we start school at the age of 6, and you can see that the face is still growing a lot, but particularly in the area below the eyes, that is the upper and the lower jaw. And now we are soon grown up. You see the typical edges of the lower jaw of a young man. Now I can tell you something that we did not know when I was a student. We did not know, although adult, that we never stop growing. The body is constantly changing for biological reasons, and growth in the face never stops, lifelong. The growth of the face never stops. Even after the age of 18, our face continues to grow slowly. You can see that here in the drawings I made of the young Johann Wolfgang von Goethe, the German poet, after the painting of Daniel Beger, and on the right there is the older Goethe after the painting of Ferdinand Jagermann. And both images are in alignment, using the eyebrows as a reference again. You can now see how much the earlobe still grows as one gets older, and the same applies to the tip of the nose. Both are made of cartilage and it will grow for a lifetime. But also the chin, become significantly further down forward, and in quite a few older individuals it's the case. That is then due to the growth of the bone. Of course, this has since been investigated in more detail scientifically, for example by Rolf Behrens, also an anatomist and an orthodontist. You can see in the superimposition of the drawings from letterhead films taken at the age of 28 and at the age of 79 on the far right how much the face has grown in these 50 years. Look again at the tip of the nose, and do you notice how much the chin came down also? We do know this only because people nowadays can keep their own teeth lifelong. In earlier times, more people than today did have full dentures after complete loss of their teeth. Then the vertical dimension of the faces has been established by the dental technician in the lab. And here you can also see very clearly how facial growth continues throughout life. This adult patient received implant restorations in the region of the upper premolars in 2013. At that time, they were in a perfect occlusal fit. 5 years later, he presented to us with an open bite right there. And in addition, we can see on the first molars, they were slightly distal in 2013, but in 2018, the vertical fissure between the cusps of the lower molar now fits exactly under the distobuccal cusp of the upper first molar. So, as you see, the mandible or mandibular dentition has come forward over the years. And now he has a traumatic pre-contact in the entire anterior incisor group. He notices that it hurts him, and yes, he no longer has an adequate occlusion in the posterior region. And since the implants cannot move, they cannot follow the growth, we now see further evidence for ongoing growth. And here the alveolar process and also the entire mandible have grown significantly in the last 5 years. Unfavorable skeletal growth can have deleterious consequences for the development of the dentition. In this case, there is a Class II Division I malocclusion with an extremely increased overjet and with a deep bite relation. The lower anterior incisors do not find any support on the upper teeth, but continue to extrude until they finally hit into the palatal mucosa. This is then a condition that leads to a permanent traumatization of the palatal marginal periodontium, indeed, a very unfavorable prognosis for the future of that dentition. At the time of the main growth spurt, the mandible should have been treated in order to achieve a neutral occlusion. And now the lower lip is still lodged in that enlarged sagittal overjet, which further aggravates the situation. And after all, we can learn here that when the teeth keep erupting, as here the lower incisors, that they take with them their periodontium and their gums and their bone. So you can see that there's a vertical step of more than half a centimeter in the level between the canine and the incisor teeth. This biological knowledge can be used therapeutically in other cases. This patient shows a Class II Division II malocclusion. The upper incisors have over-erupted so much that they cover the lower front teeth. Some people call it a covering bite. The lateral view shows what has happened. In the lateral head film, we see that the mandible, as a body, actually wanted to grow. Well, it has, after all, grown well. However, the teeth on the mandible, altogether the dentoalveolar portion, that is what did not grow so well, forward direction. This was prevented by the lower lip, which was kept so snugly over the upper front teeth that they were forced backward in a backward position. As a consequence, the whole dentition of the lower jaw did not have the slightest chance to come forward, as the underlying mandibular body did do it. And therefore, the occlusion is half of a bicuspid with distal. And therapeutically, one should have much earlier intervened with holding the lower lip away from the teeth. The upper front teeth should have been protruded and intruded so that the way would have been clear for the lower dentition to find its proper position and interdigitation. And here the situation is difficult. We see a hypoplastic maxilla. The nose is hardly used for breathing, and the lower jaw is then also pushed further forward by the tongue, and also the teeth, as you can tell from the interdental gaps, are coming forward. And therapeutically, the nasal passage should be checked first, and the perioral musculature should be trained in such a way that the child manages to close the mouth. However, it is a difficult case, and in the end, the only option would be to widen the upper jaw and to try a forward protection, possibly with a face mask. And this situation is even more difficult. A frontal open bite with a pronounced vertical skeletal growth pattern. Even a transversal expansion of the posterior part of the maxilla would hardly bring the anterior teeth into a physiologically correct position. And therefore, a surgical intervention, probably a bimaxillary osteotomy with orthodontic pre- and post-treatment, might be necessary here. The take-home message. We have somewhat approached the complexity of facial growth. We have seen the dramatic differences in proportion that take place during facial growth and the role that the dentition development plays during facial development. The mechanisms of bone remodeling was addressed, as well as the location and the importance of the growth of the sutures. And also the lifelong growth of the face has been addressed. And finally, some clinical notes. And with that, I thank you for your attention to this lecture.